um, everyone. Today I just want to wish you everyone very happy Diwali and a prosperous and abundant Diwali and safe Diwali to everyone. And from my side, um, to each and everyone in the whole world who are celebrating Diwali, and celebrate the Diwali with caution, precautions, everything. And happy Diwali all. Today I just want to tell you abnormalities of the menstruation or menstrual disorders, and amenorrhea, palm coin classification, and menorrhagia and all these things today we will discuss in detail. Okay. um, okay, first of all I just want to tell you about, see guys, I have completed the anatomy and physiology and menstrual cycle. I have completed those things in the previous sessions. Please, if anyone who doesn't attend for the live class, or else who doesn't see the see those videos of anatomy of the uterus and anatomy, physiology, and menstruation in nutshell, everything is presented. I have uploaded at ortho flash videos. Just please go and watch before this class. And if you are attending very newly to this class or first time to the class, please go and watch those videos. Myself, I am Vijay Durga. I am an orthopedic resident, and now I am doing my fellowship in obstetrics and gynecology because I love the subject. And in the orthoflash videos I have already uploaded more than 65 videos regarding orthopedics. And those videos I just have made the syllabus entirely from the textbook itself, so you can revise each and every chapter within 2 to 5 minutes. So it is really helpful. And now I'm doing my fellowship, so I'm adding the concepts and uh, lessons regarding the obstetrics and gynecology also. So today I just want to start the abnormalities of the menstrual cycle. Okay. Hi everyone, how are you all? Each and everyone, please happy Diwali, celebrate Diwali happily and safely. How are you all? Hi everyone. Okay, I'll continue the class. Just please just follow the class. Already I have mentioned the anatomy, physiology, and menstruation in nutshell. All these things I have already uploaded at the orthoflash videos. So now I'm talking about now I'm teaching about the disorders of the menstruation, amenorrhea, and disorders of menstruation, and menorrhagia and all. Okay, today we will discuss those topics and all. First of all, menorrhea. I have already told about what is menarche, at what time, or at what age puberty at times, and all these things I have discussed earlier. Now I'm telling about the what is amenorrhea. Okay, what is amenorrhea? Amenorrhea is nothing but there is no menstrual cycle. No menstrual cycle is called amenorrhea. Okay, there is no cycles, no bleeding, no spotting, nothing at all. This is called amenorrhea. So amenorrhea is of two types: primary amenorrhea and secondary amenorrhea. Primary amenorrhea is again two types, that is of physiological amenorrhea and pathological amenorrhea. So physiological amenorrhea is quietly observed before the puberty, at the time of pregnancy and all. So these are physiological conditions while lactation and all. All these are physiological. Coming to the pathological amenorrhea, there are lots of reasons for the amenorrhea, whether it is primary amenorrhea or secondary amenorrhea. Coming to the primary amenorrhea, There are lots of causes or etiology. Like, first of all, always remember three stages before the puberty, at the time of puberty or adolescent, or um, during the reproductive age group, postmenopausal age group. These are the segments are happening, or these are the segments of a woman's life. So at each and every state, how the at since birth or in intrauterine period, how these hormones helpful for the a baby development, especially a female baby development. Okay, see, now I'm telling about those conditions which are, which leads to amenorrhea. First of all, coming to the primary amenorrhea, there are three types of amenorrheas, like hypergonadotrophic amenorrhea, eugonadotrophic amenorrhea, and hypogonadotrophic amenorrhea. All these three conditions we have to remember. So these are the three conditions where the classification depends upon the gonadotropin level, that is FSH. So FSH is the main thing in all these spectrums. So what is the level of FSH we have to remember? So FSH level is 45 um, international units per ml. So if the FSH is level more than 45, then it is called hyper. If it is normal or equivalent to 45, that is the normal condition or eugonadotropic. Hypogonadotropic is nothing but the low level, less than 45 international units per ml, that is FSH. And also remember, estrogen or estradiol 25 picogram per liter or less than that. Estradiol is less than that. So all these are the ranges we have to remember. Okay, so these are the conditions, guys. We have to pay attention while knowing about the amenorrhea. Coming to the diagnosis, or while we are diagnosing a amenorrhea patient, or while a girl child or a girl child, lady or woman, whoever presented to the clinical OPD or to your clinic, then how will you evaluate the patient? The things you have to remember. First of all, always remember, male or a female, we have to look for the secondary sexual characters. Those are the things we can tell you that by seeing is there any abnormality or not. Okay, so secondary sexual characters are very much important. So what are the secondary sexual characters? Everyone, hi everyone. Secondary sexual characters are pretty much important. So while seeing the girl child, just we have to see the facial hair is present or not, like upper lip hair or beard hair or not. We have to see, is there a good development of the breast according to the age, whether the breast is developing or not according to the age. We have to look for that. So this is we can analysis by seeing the girl child or a lady or a woman. So next we have to ask for her that is there any development of axillary hair or pubic hair or not, any abnormalities, or is she felt any difficulties in during her development period, like after 12 or 14. Okay, during those time we have to ask her that is there any problem, how she attend menarche, when she attend menarche, anything we have to ask. Okay, so second, what I want to tell you is that is the secondary sexual characters are the important. Okay, after that we have to examine the height of the patient. So height of the patient we have to see. The person who came to your OPD, just check the height is whether she is appropriate height or not. She is tall or short. She is tall or not, she is short or not, whether we have to see. Okay, these are the things very important. First of all, whether she is short or tall, we have to see. If she is tall, just go for analysis, like first we have to see the FSH levels and LH levels. Okay, FSH levels increased or not, we have to see. LH levels increased or not, we have to see. So first of all, FSH levels increase or not, we have to look for it. After that, if FSH levels are increased, then there is a problem in the ovaries itself. Okay, there is a problem in the ovaries. Then we have to go for look for the karyotypes. Okay, karyotyping, Turner syndrome, female or XTO, we have to see. Or is there any testicular feminizing syndrome present? Okay, testicular feminizing syndrome is present, whether or not, we have to see. So after that, karyotyping is essential. So why these are important? Because karyotyping in the Turner syndrome female, there is no development of the breast. Everyone knows that there is a shield chest. Okay. So there is an appearance below. After Turner syndrome, in the Turner syndrome female, is she developing? Then we have to see the FSH levels increase or not. Okay, FSH levels are normal. Then okay, if FSH levels are normal, then go for the estrogen levels. Is estrogens are normal or not, have to see. And after that, how to manage and all, after that we will discuss in the if secondary sexual factors are absent, and then go for secondary sexual characters are absent, then go for go for FSH levels second, and go for USG. So in the USG, if you find the uterus is well and good. If there is no uterus or absent of the uterus, you observe absent of the uterus, just I think it is because of Mullerian degeneration. Okay, Mullerian degeneration and RKH syndromes, everything that. Okay, everything comes into the abnormal development. Okay, that if uterus and vagina is absent. Okay, in those patients ovaries are present. So how to manage those patients, we will discuss in the management section. And if uterus present, go for a check for the FSH levels. If FSH levels are normal, or if FSH levels are increased or not, we have to see. And again, estrogen level, and you have to also go for check the entire hormonal profile. If she is if she is developing secondary sexual characters on the USG, uterus is normal, ovaries are normal, everything is normal. If the entire her reproductive system is normal, then you will go for the hormonal profile. Hormonal profile should include FSH, LH, estrogen, progesterone, and prolactin levels. All these are important. And how to manage these things. This is the this is how we diagnose a primary amenorrhea. Primary amenorrhea. A girl or a lady who came with primary amenorrhea and all. Coming to the secondary amenorrhea. How to diagnose a patient. Secondary amenorrhea is nothing but there is no menstruation for the period of 3 to 4 cycles or 6 cycles. There is for 6 months, at least for 6 months, if there is no menstruation after attainment of the menarche, then it is considered as the secondary amenorrhea. In the secondary amenorrhea, how to diagnose the patient. So in secondary amenorrhea patients, we will do the progesterone challenge test. In the progesterone challenge test, what we give is, we give the progesterone, the progesterone how we give, and cyclical progesterone, or in the progesterone challenge test, we will give only 5 to 10 like cyclical progesterone we will give for the regularization of the cycles. In the progesterone test, in the progesterone challenge test, we will give 5 to 10 mg of progesterone to the girl or a woman or a lady. We will give her 5 to 10 mg daily for 5 days. If there is any progesterone withdrawal bleeding is present, that is the confirmation of the anovulatory that is the confirmation of the anovulatory cycles or anovulatory cycles. Why I am saying saying this, if you are giving a progesterone, then there is an withdrawal bleeding. That indicates the level of progesterone is not up to the mark, or there is no progesterone production. We know, already discussed, corpus luteum produces the progesterone. When there is no ovulation, there is no conversion of the mature dominant follicle, doesn't convert to the corpus luteum. When there is no corpus luteum, no progesterone. There is no progesterone, no secretory phase. Okay, so that's how we will do the progesterone challenge test. In the progesterone challenge, if the progesterone challenge test, that means it is positive. If the progesterone challenge test, again we have to, in the secondary amenorrhea, we have to clear out, we have to clear out that the pregnancy test, because in pregnancy we already discussed that pregnancy is the normal or physiological condition where there is no menstruation. So we have to rule out pregnancy and all. Okay, this is what progesterone challenge test. After that, if it is negative, go for after progesterone challenge test, just go for the other tests like combined OC pills, or estrogen and all we have to give. If responding to the estrogen, what we are, just keep it in our mind. Okay, just keep it in our mind, whatever the hormones we are giving, or what the hormones which are giving is represents the in the person, means there is lack of those hormones. Maybe there is no production or decrease in production, or there is a problem. So HPV axis everyone should remember thoroughly and entire life, because the problem may lies in the HPV axis. HPV axis means hypothalamus, pituitary and gonadotropins. All these three we have to keep it in our mind. So after that, we progesterone challenge test, we rule out one thing, that those are anovulatory cycles. Anovulatory cycles we regularly see in PCOS condition, that is polycystic ovarian syndrome. Then coming to the estrogen, whether we have to now we have to check whether there is an efficient production of the estrogen or gonadotropins and all. Okay, coming to the gonadotropins, we have to look for gonadotropin hormone release. So what we have to see here is just look for the gonadotropin hormones released from the hypothalamus or not. Is there any pituitary gland tumors or not? We will go for a MRI scan whether there is any pituitary glands. So high level of FSH is indication for the high level of FSH is indicated is an indication for the ovarian resistance syndrome or estrogen resistance, because increase in FSH, but there is a resistance of receptors all day, so that is called estrogen resistance syndrome. Ovarian resistance is present for the FSH. So there that one thing, if there is an increase in follicle stimulating hormone, we have to look for it, and GnRH we have to see for the FSH levels and all, and see all these things we have to see by one. So USG we have to check is there any problem in the uterus, or next one we have to check for ovaries, any PCOS condition and all, and any pituitary tumors or any brain tumors, we have to see any intracranial tumors are present or not. You have MRI, you have to see pituitary tumors, empty cella, tarsica, everything we have to see. And we have to look for prolactin levels also in secondary amenorrhea, because of increase in prolactin production also leads to secondary amenorrhea. especially breastfeeding women. So in breastfeeding women, prolactin is produced um, because of estrogen and baby suckling and all. So because of that, prolactin produced, oxytocin, prolactin, all this produced. So during breastfeeding also there is no menstrual cycle. So remember thing that prolactin is also increased. Hyperprolactinemia conditions are really important. Hyperprolactinemia increased because of tumors, and also we have to see for all those things. And these are the secondary amenorrhea diagnosis. And not only that, coming to the general conditions, diet, malnutrition, obesity, diet, anorexia nervosa, all these things, renal conditions like hypercortisolism, Addison's disease, Cushing syndrome, and all those Kalman syndrome, Swyer syndrome, Sheehan syndrome. Lots of syndromes are there. Lots of um, Forlish syndrome, and LBW, one syndrome, Laurel syndrome, and all these things. These are these are comes under hypogonadism. Okay, so these are the how we diagnose the secondary amenorrhea and all. So all these things, keep it in our mind. And how we manage and all. Before that, I will need to tell some more points, like most things we have to remember that most things we have to keep it in our mind. Always remember that eugonadotropin high eugonadotropin amenorrhea, we have to keep it in our mind, because there is a Mullerian abnormalities in that in that classification. We have to look for Mullerian abnormalities. So always remember, is there any Mullerian agenesis, gonadal dysgenesis, any cryptomenorrhea? All these things comes under those things. Comes under those eugonadotropic amenorrhea and all. So gonads are well developed, but because of development of the structures, everyone knows, while in embryo stage only, Mullerian development, like Mullerian development is nothing but uh, formation of the genital organs and all. So everything we have to keep it in mind. Urogenital embryogenesis is really important. And is there any defect, or is there any defect in the Mullerian degeneration and all? Mullerian defects if present, then it comes under eugonadotrophic amenorrhea. So all these things we have to remember. So these are some of the causes for secondary amenorrhea and primary amenorrhea. And some of the syndromes which I have mentioned, I will I will tell you. And what are the most important and all. Kalman syndrome is very important. In the Kalman syndrome, patient present with anosmia. There is a neural degeneration and all. So Kalman syndrome, we have to remember. That is the one thing we have to remember in the Kalman syndrome. And Sheehan syndrome is because of after because of postpartum hemorrhage, there is no a good blood supply to the pituitary gland. So the pituitary gland get necrosed, and all these things happen in Sheehan syndrome. So that one syndrome you have to remember. And other syndromes are like these are the main syndromes we have to remember. And Turner syndrome is important. Turner syndrome is karyotypes important X4. There is gonadal dysgenesis. There is no secondary sexual characters in the Turner syndrome female. She she's a because of gonadal dysgenesis. And we have also remembered one thing, that if there is any gonadal dysgenesis, patients present with streak ovary also we can manage. In the management, I will explain each and everything how to manage the primary amenorrhea, secondary amenorrhea. Okay, now I'm going to tell about the management. So first of all, if there is a Mullerian agencies, guys, if there is an hypergonadotropic, hypogonadism, remember one thing, there is an increase in FSH because it's to amenorrhea. So for those patients, we will give the estrogen and cyclical estrogen therapy, cyclical progesterone therapy to those patients. If those patients have a streak ovaries also, there is a chance of ovulation with giving the cyclical hormonal therapy. Okay, so cyclical hormonal therapy, and that patients also go for the conception using ovulation induction, IUI, IVF, etc. So all these things helpful for a patient who suffers from the hypergonadotropic hypogonadism. Okay, coming to the eugonadotropic hypogonadism. So in this patients or in this females, main condition is related to like where the problem lies. We have to see whether it is in hypothalamus, whether it is in pituitary gland, whether it is in ovaries or uterus. Everything we have to see. Then mostly in this section we have to remember PCOS, polycystic ovarian disease. See Rotterdam criteria, or I have also mentioned in the previous class. Rotterdam criteria, there is a reversal of the FSH-LH ratio. There is a reversal of the LH. There is reversal of the LH-FSH ratio, and second, there is an increase of the hirsutism, anovulatory cycles, and all these things mentioned in the Rotterdam criteria. So you have to remember that. And hypogonadotropic hypogonadism also. Hypogonadotropic hypogonadism, we remember that. See, always think in hypogonadotropic hormones are stress related things. Always remember hypertension, any stress related, like stress related conditions. Okay, hypertension, stress related conditions. If the patient has more adrenaline, because of more adrenaline also used to amenorrhea. And low cortisol levels, a girl with low cortisol level has a very lean muscle mass. You have to remember that. Cortisol is also important, and noradrenaline is also increased. So all these things in hypogonadotropic related amenorrhea because of stress and all. So all these things we have to keep it in our mind. See, amenorrhea patients are mainly, these are the complaints. If primary amenorrhea, there is no attainment of menarche. During puberty, there is no menstruation. Okay, there is no menstruation. And if in the reproductive age group, the main complaint is the infertility. How we deal with the infertility and all, I will discuss in the management. Okay. So this is how the these are the problems related to the amenorrhea and all. Okay, all these things. So I will take some break. Okay. I will take a 5-minute break, and I will tell the management and all. Thank you all. Guys, please subscribe to Ortho videos, guys. Just please go through all the 65 videos. Literally helpful to you. A quick revision if you want. Just go through those videos and follow the Autoflash videos. Please subscribe and please subscribe to Autoflash videos. I'll continue the class. I'm taking 5 minutes break. Um,